Hi, welcome everyone. Uh, I'm so glad to have so many of you here in the room today for our chords highlights. Um, and I see that we have several folks on Zoom today as well. Um, I'm Sarah Brewer. I direct our education program as part of our training, education, and mentorship core at Accords. And I want to welcome you all today to our Accords Highlights Fellowship Edition. Over the last year, we've made some changes in our educational programming. So if you haven't joined us this academic year, uh, welcome to our new Accords Highlights format. In reflecting on our successes and our future direction, we identified a key and ongoing need to share the stories of our Accords investigators and fellows with each other and with the world. And that's really the genesis of how we landed here with our Accords Highlights series. We want to truly highlight and share the methods, tools, and most importantly, the impacts that our Accords investigators are having on the health and well-being of people across clinical and community settings. So each quarter, we are highlighting two Accords investigators and the work that they are doing. We share lunch, discuss their important research methods and findings, and have discussion about the work that our Accords teams are doing. For those of you who are maybe even newer to us, and this is your first time interacting with Accords, I want to share a little bit about who and what we are. We're something of a one-stop shop for pragmatic research. We're supported by the University of Colorado School of Medicine and Children's Hospital Colorado. And we are an environment for faculty to conduct pragmatic research, receive various types of services and supports for their grants and projects, along with incredible mentorship, training, and education in health services research, including our two fellowships, which we are specifically highlighting today. Right. As we get started, I want to highlight a couple of other things that are coming up soon, so you can mark your calendars. The first is our D&I Science for Researchers workshop, which is coming up in about a month, April 8th and 9th. Applications and registration are open, and this is in a dual format. We do didactics in the morning and intensive workshopping of a developing project in the afternoon. And folks have the option to attend just those didactics or attend both parts of those days. Then we also, at the end of April, April 24th, have our Community Engagement Forum, and this is our community showcase. So we are really excited to have Nina Wallerstein, a real dynamo in the CBPR space, joining us with a community partner to speak. And then we will have community partner organizations highlighting their work as well. And then lastly, we have CopperCon, the Colorado Pragmatic Research and Health Conference, May 20th and 21st. And we are really excited to have 7 amazing pre-conference opportunities as part of CopperCon this year. I personally would like to attend all 7 of them, but unfortunately you will have to choose. But everything about our pre-conferences is up on the website at coppercon.com. All right. As I move toward introducing our speakers today, just a couple of housekeeping items for folks both in the room and on Zoom. First, if you are on Zoom, please go ahead and use the chat liberally. We want to hear your comments, your thoughts, and we will use that to help with Q&A at the end of the hour. For those of you in the room, hold on to those questions. We have dedicated time later in our hour together. And then second, we hope everybody, no matter what format you're here for today, will complete our evaluation at the end of the hour. It really helps us to identify what we're doing well, so we can keep doing that, but also to continue to meet your needs into the future. Okay. Now on to the most important part. I am really excited to welcome 2 of the fellows in our Accords Fellowship programs today, Emily Dunstan and Megan Abbott. Dr. Emily Dunstan is a second-year T32 primary care research fellow at the University of Colorado Anschutz Medical Campus. She holds a PhD in health and kinesiology from the University of Utah. Dr. Dunstan is also the inaugural National REAIM and PRISM Consortium Fellow, and her research spans primary care, oncology, and geriatrics, with a focus on leveraging dissemination and implementation science methods to deliver exercise programs for people living with cancer in oncology and primary care settings. She aims to develop pathways to support referral to cancer rehabilitation and exercise services, particularly for older adults with cancer. And after we hear from Emily, we're going to hear from Dr. Megan Abbott, who's a pediatric epileptologist at Children's Hospital Colorado, embarking on a career in clinical research focused on outcome measures in developmental and epileptic encephalopathies. She's working on establishing new multidisciplinary clinics, generating gene-specific data sets, and devising outcome measures applicable to various DEE populations. Having grown up with a brother with special needs, she has both a personal and professional connection to working with rare disease families. She's excited to begin this work with the hope that we can advance further towards clinical trial readiness and disease-modifying therapies. Please join me in welcoming Emily Dunstan and Megan Abbott today as they present Building Impactful Health Services Research Careers. Welcome. Erin, this is working as well. If you feel like you have to move around a little bit.
Hi, everyone. It's great to be here today. I think we tested our introductions there. We put as many big words as possible just to test Sarah. But I just want to highlight the T32 funding as I go to present, but I have no other personal or professional conflicts to report. So to start off, I want to highlight how I got into the primary care research fellowship, as I am not a clinician. And I did start in sports science, so it's a little bit of a winding journey. I started with a bachelor's of exercise science, and my very first research project, I was testing blood lactate levels out on a track with college athletes and testing different recovery positions to see which would be most optimal for recovery. But in doing so, I felt like I was applying my physical activity research lens from making the 1% better. And in my work, I really wanted to help everyone get the benefits of physical activity, which led me to shift and apply my exercise science training to a chronic disease population for my doctoral training. And I really focused on the cancer space and developing and delivering exercise programs for people living with and beyond cancer. And I heard firsthand from patients how beneficial these programs were, but still recognized how little access patients had to these programs and how important it was to get these programs to the people who needed it, which led me to the University of Colorado and the Primary Care Research Fellowship, where I was really interested in building not only skills and working in a new clinical setting, moving from the oncology space to primary care, but also gaining skills in dissemination and implementation science. So that's what I'm going to talk to you about today. So cancer survivors often face numerous long-term effects of cancer treatment that vary depending on the type of treatment received. And this can make cancer survivorship care really complex. And survivorship care is primarily provided by primary care physicians who don't necessarily have specialized training in cancer. However, there are a lot of supportive services that have been developed to help support cancer survivors and the people who are caring for them, optimize their well-being and quality of life following diagnosis of cancer. And in this process, there's also a lot of older adults who have been diagnosed with cancer. So not only are they facing a cancer diagnosis and all the complications that come with that, but also all of the effects of aging, which can make this really complicated. And so cancer rehabilitation and exercise services can help address some of the changes we see not only with cancer, but also with aging. And meeting the physical activity guidelines is a key way that we can help older adults with cancer optimize their physical function and quality of life. So cancer rehabilitation and exercise services, which I'll refer to in this presentation as CARES, are widely available across the United States. You can see in this map that cancer exercise programs are represented in red, and those are programs that are delivered by exercise physiologists that have specific training in working with cancer populations. And then the cancer rehabilitation programs are represented in blue, which are typically delivered by physical therapists and occupational therapists and target more specific needs than general function, which is what exercise programs target. And overall, there's pretty good distribution across the United States. You can see that the few darker shaded areas are areas where patients might not have good access to one of these programs, but there are virtual programs. So if people have access to internet, hypothetically, they should have access to a CARES program. There's a substantial body of evidence suggesting that CARES are really beneficial for numerous outcomes, not only for cancer survivors in general, but also specific to older adult cancer survivors. Things like improving quality of life, improving physical function, decreasing cancer-related fatigue, and generally also improving symptoms of anxiety and depression, though the evidence in this area is still emerging for older adults. Despite the numerous benefits of CARES and also the wide availability of CARES programs, there's still really limited awareness of the CARES programs among patients and also clinicians. However, a referral from a healthcare provider has been identified as a key facilitator to patients engaging in CARES. Yet only 10% of cancer patients report receiving a referral from a healthcare provider to a CARES program. Currently, there have been efforts to improve cancer rehab and exercise referrals in the oncology space. However, there haven't been any efforts specifically targeted at primary care, despite most survivorship care being delivered by primary care providers. And 90% of cancer patients see a primary care provider at least annually, suggesting that this may be an area of untapped source of referrals for CARES programs. Which brings me to the aims of this study, which are to explore the perspectives and characteristics of three key groups that are involved in CARES referrals. First, older cancer survivors, defined as those 65 years and older with a diagnosis of any cancer type, primary care providers, and then also CARES programs directors. We also sought to iteratively refine a prototype CARES referral process to specifically tailor to the needs of primary care clinics in this study. So we used PRISM, or the Pragmatic Robust Implementation and Sustainability Model, to guide the study. And as many of you are familiar with PRISM in this audience, but I just wanted to highlight specifically how we conceptualized it for this project. You can see that we had our three key groups highlighted there in orange, yellow, and red. And then we also considered the re-aim outcomes, but our main focus was really on the blue and yellow boxes for this study. It was really important to address the multi-level perspectives of each of these groups in the study, because if any one of these groups said, not going to happen, I'm not doing that, the referral process would not work. So including all of these groups was really important to make sure we could clear every step of the process. So we used purposive sampling to recruit participants from each of these three groups. We recruited older cancer survivors, as I mentioned, who had any cancer type, but also any cancer stage we included in this study. And they had both participants who had participated in CARES and not participated in CARES were part of this project. So we could have both perspectives of people who had gone through the process, how they might like it, but also how people who maybe weren't aware from CARES, how they would want to learn about these programs and what would motivate them to participate. Then we included primary care physicians. They worked in any of the UC health clinics that regularly saw older adults in their practice. And then also CARES directors who manage either a rehab program or an exercise program, as it was really essential to understand how they were receiving these referrals, not just how we would place the referrals. So we conducted semi-structured interview guides to elicit the perspectives of these three groups and get feedback on our initial referral workflow. Interviews were conducted via Zoom primarily, with some on the phone to meet the needs of our older adult participants. And interviews were about an hour on average. Of the interviews, once we had all the interviews complete, we transcribed them verbatim and then de-identified them prior to analysis. For analysis, for both rounds of interviews, we analyzed the interviews using a rapid qualitative approach, which is an iterative team-based approach. And this is where I want to highlight the support of the Primary Care Research Fellowship. I was able to have both a qualitative analyst and qualitative methodologist support this work, as rapid qualitative analysis was a new to me skill. So that was a really critical infrastructure for this work moving forward. So with this process, we developed a summary template as well as a matrix, and we summarized each interview individually following the completion of the interview using the summary template. Then we input the summaries into the matrix overall, and we had a separate matrix for round 1 and round 2 since the interview guide did change a little bit between the 2 rounds of interviews. Then we analyzed the data, analyzed the domains across all of the interviews, and developed our key findings from there. We had findings both on the perspectives, as you'll see, and then also key targeted points of feedback on our workflow. So this is a simplified version of what the matrix looked like. Only 3 domains are showed here for readability, but we did have 15 overall. And these domains were harmonized as much as possible across the 3 perspectives so that we could really see how the perspectives of the primary care providers and the patients and the cares directors all interacted. However, there were a few domains where only one perspective was applicable. For example, we had the cares directors explain their program and the process of getting referred to the program, and then also what it was like to engage in the program, which was only really relevant for cares directors. We also mapped each of these domains onto PRISM domains. So we had that as well. PRISM helped guide our analysis. All right, so now getting into some of the fun parts. So I'm going to present the demographics for both rounds of the interviews and then the findings from round 1, followed by the findings from round 2. So across all the interviews, we had 5 cancer survivors participate, ranging from 65 to 80 years of age. We had 4 cancer types represented in this sample, all of which were between stage 1 to stage 3, so no advanced cancer patients. We had 6 primary care providers from general internal medicine, family medicine, and geriatrics clinics participate. And on average, primary care providers had been practicing for about 14 years. In terms of cares directors, we had 7 of those participate across both rounds, 2 of which were rehabilitation directors and 5 of which were exercise program directors. Most of the cares directors had been in their role for 5 or more years at the time of the interview. So I mentioned that we did 2 rounds of interviews. In the first round, we showed participants this initial cares referral workflow in the last 15 or so minutes of the interview. And the workflow had 3 steps. And for each of the steps, we gave participants options of how we envisioned this process might look in their clinic. And then they told us which was their favorite, or if they did not like any of our options, they would like to propose a different option altogether. So this is what that kind of looked like for step 2. You can see we provided them with 3 options. And they were able to go through and tell us what they liked and didn't like, or maybe create a combination of options that worked for them based on their needs. So we did that for each of the steps, just presenting this here for step 2 as an example. So from our first round of interviews, the need to educate primary care providers about cares was a key emergent theme. None of our primary care providers or patients interviewed in round 1 were aware of CARES programs at all. However, they were very interested once learning about them in the interviews, about the possibility of participating in the programs or referring their patients to these programs. PCPs stated that they would need to know a little bit of the basic information about the CARES programs to feel comfortable referring. Things like, how many times a week does this program meet? How individualized is it to different functional needs? Those sorts of things, because they knew patients were going to be asking them those questions and they wanted to have the information ready when they went to make or have that conversation with patients. The preferred channel about sharing information about CARES was really either in clinic-wide meetings that were already happening and already on the primary care provider's schedules, finding a way to get a few minutes of those meetings to share some information about CARES, or either emails that came directly from the clinic director or other trusted members of the clinic team that primary care providers were used to getting emails about. They didn't want me sending them an email. They told me, I will not read your email. You need to get that email to go through a channel that I'm used to looking at. Now getting into the steps that we showed our participants, for the first step of identifying eligible participants, most CARES have really broad eligibility criteria. Really, patients only need to have a diagnosis of the cancer to be able to participate in these programs. However, identifying patients who do have a cancer diagnosis in primary care clinics can be difficult, and that was identified as a key barrier to being able to initiate this referral process and making these referrals. Further, each clinic has a different check-in process, a different rooming process, and different support staff to support the clinical workflow. So understanding who to engage in this process to support primary care providers was raised as a key concern. And then patients wanted to be involved. They didn't want their provider to look at a eligibility criteria list and make this decision without them. They wanted their provider to bring this to them as a possibility and really have a conversation with their provider about whether or not it would be a good fit for them. Particularly one patient raised the concern of I haven't seen my primary care provider since, before I was diagnosed with cancer. They don't know whether or not I've already participated in a program like this or not. So those concerns from the patient perspective were really important to include them in these conversations. All groups felt like a discussion about CARES during the visit was essential, as I just highlighted from the patient perspective. Both CARES directors and primary care providers felt like a resource of information about CARES would be really useful. So some summary of the different types of information they would need to know, like cost of the program, where the program was located, how patients can get involved, where they can find more information, those sorts of things. Further, participants or patients and directors suggested that a follow-up message following the visit would be really helpful, but the follow-up message alone was not a good strategy. This could be used to share information with patients so that they could follow up on things on their own, but the conversation was still really important and should only be used in combination with the message and the conversation, not just using the message by itself. The last step in our process was actually making the referral. And currently, CARES referrals rely really heavily on word of mouth. So a lot of patients are finding these programs by talking to other patients, or maybe they know someone who is connected with the program in some way. But rehab programs are still receiving referrals, and exercise programs have received referrals from providers. Overall, most groups felt like having the option to either self-refer or having the provider place referral was good. There were some concerns raised from the patient perspective that self-referrals alone might fall to the wayside. They might not follow through on those referrals necessarily. So if the provider had a way to place the referral, that was preferred by patients. But providers felt very strongly that this needed to be integrated into the electronic health record, that it should not be on an external website or some other way that they would have to make an extra click. Making it as easy as possible and as seamless as possible was very important to them. Directors, on the other hand, were okay with the EHR referrals, but did have some concerns. They are not using EHR systems on a daily basis, and they were wondering how they might gain access to these or how these referrals would come to them if the provider was placing them in the EHR. So overall in round one, we heard that referrals to CARES from primary care are acceptable across all three groups. However, there is already so much on primary care providers' plates that they have to do on a daily basis that this process really needed to be as seamless as possible and integrated as well as possible into the clinical workflow for it to be feasible. And we also heard that promoting awareness about CARES and leveraging existing referral processes would be really critical to implementation success. So this led us to scrap the referral alone, which we thought would be sufficient, but it turns out it's more complex than we thought it would be. And PCPs really wanted more support than a workflow by itself. So we decided to develop a clinical decision support tool to help guide them through the process in a way that they could have that conversation with patients and make a shared decision about whether CARES were appropriate for the patients. So from that, we then developed this prototype clinical decision support tool. This is what it looked like after round one, before round two. And in this first step, it was really about understanding, okay, should we even have this conversation with a patient? Is this patient a good fit for having a conversation about CARES overall? That's this first half. And once we get to, yes, it is a good fit, or no, it's not. If it's not, then we do not even need to look at the second half of the clinical decision support tool. But if it is, then this portion of the clinical decision support tool helps providers navigate, well, is rehabilitation or exercise a better fit? And how do we get them there? So instead of showing participants in the interviews the workflow that I showed in round one, we then transitioned to showing this prototype clinical decision support tool at the end of the last 15 minutes of each interview in round two to get targeted feedback on how this process would look. And boy, did we get a lot of feedback. Most of it was really positive overall. People were generally like, yeah, this makes sense to me. I can follow it. There were some questions about terminology, a lot of questions about where it would show up in the EHR. We got a lot of great feedback about the possibilities there. But overall, really positive feedback. However, we did get a lot of suggestions for improvement, which I've summarized on the slide. The big thing I want to highlight from this slide is that overall, most of these feedback pieces that we were getting came from more than one group. So usually PCPs and patients, or PCPs and directors, were highlighting things. PCPs had strong feelings, which is fair. They're the ones who are the end users of this tool. But overall, there was pretty good consensus about the feedback that was being delivered. There were a few things that were highlighted that were unique to a single perspective. For example, patients really wanted to to be asked if they had already participated in a program like this. They felt like that was really important to know that whether or not this conversation should move forward or how this conversation should move forward. And then directors really wanted PCPs to understand what the difference between rehab and exercise was so that the patients they were getting referred to them were really a good fit for their program. And so after we got this feedback, we incorporated the feedback, we made the changes, and then we sent the feedback back to the participants. And overall, this is kind of the summary of what we heard from round 2. Again, the need to integrate the clinical decision support tool into the EHR was critical for feasibility and long-term success, and that the implementation of the clinical decision support tool really need to be tailored to each individual clinic. So what works in geriatrics is probably not going to work in internal medicine. We need to develop a way to make sure that these processes are tailored to each primary care clinic. And last, there was a need for a supporting library of information or some way to have a quick reference for primary care providers who are not seeing every patient as a cancer patient to understand which programs are available to their patients and the different information about those programs so that they can connect the patients who need them to these programs. So next steps, we currently have this in a low fidelity prototype, and we are getting ready to turn it into a high fidelity prototype clinical decision support tool to prepare for piloting the implementation of this tool. One thing to highlight about how the T32 Primary Care Research Fellowship has supported me, sorry, too many grant letters, is that I submitted a K-99 with support of the T32, and that was reviewed well, and we're waiting on a funding decision for that to be able to keep continuing this work forward from there. So fingers crossed for that. But wanted to just wrap up by highlighting the mentors that supported this work. Have been really fortunate to work with some excellent mentors and really got feedback from every single one of the faculty members on the primary care research fellowship throughout this process. I don't know how many times they've seen that workflow in different stages. Getting feedback from all of them, their different unique perspectives was really useful, and I think helped me bring a better version of that prototype to my participants before they even saw it. So I'll end there and excited to take your questions later. Thanks.
Okay. Thanks, Emily. This is so fun because Emily and I get to hang out all the time together during work in progress sessions and mini lecture, which is great. I'm Megan Abbott. I'm one of the SCORE fellows. I'm in my second year of SCORE fellowship, and I'm really excited to talk about kind of what I've been working on and what I'm hoping to work on in the future because of SCORE. So I'll just start off. My objectives are just to talk about my research work and then how SCORE has impacted what I'm working on and what I'm able to do due to the resources Accords has afforded me. And so a little bit about me, different path than Emily to getting to research. So I'm a pediatric epileptologist at Children's Colorado. I actually went through undergrad studying neuroscience, came to residency here for pediatric neurology training. Had no idea that I was going to do research, do not have a PhD or any kind of advanced research degree. But in the midst of my medical training, kind of as a third and fourth year resident, became really interested in genetic causes of epilepsy and started to be involved in clinical trials and realized that while the science of creating drugs for clinical trials had advanced a lot, we really didn't know how to measure outcomes for these clinical trials that were being developed at a rapid pace. And so quickly got kind of integrated into the research world and realized that SCORE was an opportunity. So was very thankful to get to be part of SCORE once I became faculty after residency and epilepsy fellowship. I'm currently the medical director of several gene-specific clinics at Children's, which helps kind of populations for me to have for research, including the SYNGAP clinic and the CN2A8A clinics. Like I said, I'm focused on outcome measure and endpoint development in rare disease, and I'm a second year SCORE fellow. So I think when I start kind of talking about my work and what I'm interested in, people are often like, well, what's wrong with the way we're doing it right now? Why can't we just measure outcomes the way we've always been measuring them in clinical trials? And most of the time I'm talking to epilepsy docs when I do this kind of talk, and how drug trials have been run previously is using seizure frequency as your primary endpoint. They're pretty quick trials, 3-month trials for a medication. You see that seizure frequency gets better and you're done. Unfortunately, in the emerging world of disease-modifying therapies, so we're talking about ASOs or gene replacement therapies, these are therapies aimed at improving a whole condition, right? These are therapies that are supposed to kind of improve not just seizures, but developmental endpoints as well. And these are long trials. They're 2 to 3 year long trials. And so the outcomes we're going to need to measure are very, very different. And we also need to be taking into account the perspectives of the caregivers, which I'll get into a little bit later, as well as be able to measure not just seizure frequency, but small, meaningful changes in a lot of different domains to prove that a therapy is effective. And there's a lack of outcome measures validated in rare disease in general, or any specific genetic condition that I'm going to talk about. And so seizure frequency is not going to work for these trials, as I've said, for a lot of different reasons, but a couple that I like to point out is that in genetic conditions that cause seizures, developmental delay, intellectual disability, other challenges often precede or subsist past seizures. So seizures can crop up, we treat them, they get better, but developmental delays and other impacts really persist. And then there's certain seizures that are very hard to track. Quick myoclonic jerks, infantile spasms. These are not what the pharmaceutical companies call trackable motor seizures, which means that they're not valid in a clinical trial. And so for conditions that these are their primary seizure types, that no longer is an effective outcome measure. And so we really have to figure out how we're going to measure change in a clinical trial for those conditions. And one thing I'm pretty passionate about, I think people heard my personal background, but having a brother with special needs as well is just taking that patient perspective into account. So a caregiver, a patient, they're going to go through this really intense clinical trial. An ASO is a drug that's usually done through a lumbar puncture or through a port into the brain. A gene replacement trial is given via a viral vector, which involves all of its own complications. These are very serious, high-risk therapies. And so there really needs to be a lot of benefit for a patient to go through this kind of therapy. And so a small change in seizure frequency or a small change in how they move is not going to be enough to justify the risk of these therapies. And so there's been a lot of really good work done on what we should be measuring and what patients and families care about. So in a certain type of genetic epilepsy, and I'm going to talk about a lot of letters and numbers, I apologize, but in general, I'm just talking about genetic causes of epilepsy, one of which is CDKL5 deficiency disorder. And in a study of parents with that condition, they noted a lot of top concerns, and you'll see that epilepsy and seizures is up here, but so are a lot of other things, such as developmental delay, speech concerns, feeding concerns, sleep concerns, visual impairment. There's a lot of things that parents want to get better within these types of clinical trials. And so we have to figure out how to measure those things. Same thing is true of a lot of other genetic conditions. So I'm just going to run through these slides, but Angelman syndrome, STXBP1, a lot of work has been done in different genetic conditions showing that families have a lot of concerns that they want improved through these types of clinical trials. And oftentimes in this field, we call this a disease concept model. So this is often qualitative interviews done with patients, caregivers, physicians to generate what's called a disease concept model, or the top domains or top concerns of a patient has with these conditions. And so you can see for this STXBP1 disease concept model that there are a lot of different domains that are affected and that patients and families find important. So overall takeaways, and this is kind of framing my work, is that while epilepsy is a major concern, it's not the only concern, and that's coming from an epileptologist. And so disease-modifying therapies really need to be aimed at a lot of these different concerns. And so we need outcome measures that can consistently measure different domains such as speech, motor, sleep, vision, and we don't currently have those. And so my work is in taking an outcome measure that was designed for CDKL5 deficiency disorder and seeing if we can apply it to multiple other types of genetic epilepsies. The work that's been done in this space so far has really been focused on one gene at a time. So take Rett syndrome, for example. A lot of work went into just developing and validating tools to measure outcomes in Rett syndrome for Rett syndrome trials. A lot of work went into designing outcome measures for CDKL5 deficiency disorder trials. But there's 900 plus, probably over 1,000 genes now that cause epilepsy that I'm talking about. And it's really inefficient and impractical to do this process for every gene that's going to cause epilepsy or every gene that's going to have a therapy. So my overall research goal is to try to take outcome measures that currently exist and adapt them for a wide variety of genetic epilepsies. So we're just going to take a quick look at the outcome measure that I'm currently working on, which was originally designed for CDKL5. It involved a large group of PIs to design outcome measures for CDKL5, two of which are at our institution, Tim Banky and Scott Demarest, and they're my primary mentors on this project. And I'm taking that work forward to try to see if we can apply them to other genetic epilepsies. Come to find out, there's a lot of steps for developing an outcome measure. When I first started this work, I'm like, oh, great. We have this outcome measure. I'll see if it works and we'll be done. But it turns out it's very complicated to prove to other people that an outcome measure is a validated, reliable tool. And so I started at the very beginning of this process, really focusing on these kind of things over here. So ensuring that a measure is fit for purpose, which is kind of a jargony word that means an outcome measure is designed for the condition that you're testing, it is appropriate for that condition, and that it is measuring what you think it's supposed to measure. And so some of that is content validity and face validity, and then piloting that measure in these conditions to see what the initial kind of structural characteristics are. So is there a nice range and distribution of scores? Are there floor or ceiling effects, meaning that all the scores are at 0 or all the scores are at 100? And so working on some of those beginning aspects of outcome measure development. I want to show some examples of items for these measures. So this is part of the clinician measure, and I work on both a clinician measure and a caregiver measure. So the clinician measure is kind of a structured neurologic exam. So as you're going through your neurologic exam, you can score these items. And then there's a caregiver measure that's a caregiver reported survey on other domains. This is an example of one of the motor items. You can see that I listed the scores there just so you can see how the measure works. A score of 0 is typical development versus a score of 100 is the most impairment. And we have items like head control, supine, lying to sitting, walking, kind of graduated levels of motor development as part of the motor domain. Similarly, for communication, have speech, both verbal and nonverbal items. And then also have a vision section that involves visual impairment, assessing, fixing, and following, eye movements, these kinds of things. And so I'm showing the results of my initial pilot, and then I'll talk through kind of the process we've gone through of adapting the measures, and then kind of the future work that I'm hoping to do following this initial pilot and adaptation. So I work with a lot of different genes and a lot of different groups. And so I started in the first year of SCORE and kind of my first year as faculty of just piloting the measure and seeing how it's performing in various different types of genetic epilepsies. And you can see, so CDKL5, just as background, is a pretty severe genetic epilepsy. And so kind of captures that severe end of the range, versus some of these other conditions are not quite as severe. And so you can see there's kind of a cluster around lower range scores, which makes sense because a lot of these conditions are not quite as impairing as CDKL5. However, I do have SCN2A, which is a very severe genetic epilepsy, and you can see that that has a very wide range of scores on the scale. So overall, though these are low numbers, I think it is capturing kind of a range of impairments, and you're able to see more mild conditions versus more severe conditions on the scale. I have even less numbers of caregiver surveys, mostly due to it being, one, difficult to get caregiver surveys back, and two, being the software we are using. I have not gotten a download of all the caregiver surveys that I have. But with these very small numbers, you can also see that there's a range of scores, but not as severe as maybe CDKL5 you would expect. I think this is nice because this is showing what I'm trying to describe, which is that all these different genetic epilepsies have kind of different fingerprints on this measure, meaning there's some that have a lot of behavior phenotype. As you can see here, like SYNGAP1 is very behaviorally impairing, but maybe doesn't have as much vision impairment as STXBP1. The higher the score, or the further out these wedges go, the more severe the impairment. So you can see there's some conditions that have a lot of behavior impairment, and there's some conditions that have a lot of motor impairment. And I think this just shows the utility of the measure, which is that I can really show the different phenotypes of these different conditions with the differences in scores. However, as you can see here and here, we're maybe not capturing the full range of impairments that some of these milder conditions have. So in doing this initial pilot work and kind of seeing how the scale performed, I realized that there's an opportunity to add some higher level items, meaning just as an example, let's say a patient with SCN1A or Dravet syndrome can walk. Almost all the patients can walk, but maybe they have trouble with jumping. Maybe they have trouble with skipping. Maybe they have some coordination challenges. That's currently not captured on this measure, which is focused on more severe impairments. And so we've begun the work of adapting the measures for some of those higher functioning skills and higher functioning conditions. And I also have the opportunity to work with Brooke and Ashley to do some of this qualitative work. And so we've begun the process of doing qualitative interviews with both clinicians and families for different genetic epilepsies, starting with Dravet syndrome or SCN1A. And we're currently in our second round of interviewing. Oh, yeah, thanks. So we're currently in our second round of interviewing to develop adaptations to the tool to hopefully get a broader range of scores for all these different types of conditions. Skip this part. So just my overall takeaways is that outcome measures beyond seizure frequency are necessary for future disease modifying therapies. Standard or off-the-shelf measures have significant limitations, and we're going to need measures that kind of capture multiple domains in order to be successful, both in measuring severity in these conditions and also for having clinical trial endpoints that measure all these domains. And that disease-specific outcome measures may have applicability to conditions outside of what they were designed for. So even though this measure was designed for CDKL5, it actually performs pretty well in conditions outside of CDKL5, and will do so even more, hopefully, after adaptation. And then I just want to talk a little bit about SCORE and how much it's been helpful to me, and then I'll wrap up, which is this, that SCORE has provided an opportunity for works in progress sessions, working with a qualitative methodologist and a qualitative analyst to do some of this work, and has allowed me mentorship and support to have a lot of advancement in the last 2 years, especially as someone who came into this not doing that much research. So getting to have multiple publications, submit manuscripts, do this qualitative work, and then also apply for extramural funding. So during the SCORE Fellowship, I have had the opportunity to receive 2 foundation grants, a NeuroNext Clinical Trials Research Fellowship and a Pediatric Epilepsy Bridge Grant. I'm also the PI of several foundation grants that support this work and support the clinics of the populations I use for this work, and have had the opportunity to work with everyone within Accords, which has been great. And so just future directions. I'm the PI/collaborator on a couple R01 applications to continue the outcome measure development work. There's a lot of people working on natural history studies for rare conditions, and there's a big need to both adapt and validate outcome measures. And it turns out not that many people are working on this. So I've gotten the opportunity to collaborate with a lot of people outside of this institution, which has been wonderful. I'm applying for a K-23 and aiming for a June submission, and SCORE's been very helpful in crafting that submission. And I'm currently working on a Master's of Science in Clinical Science. So with that, I want to thank everyone here for supporting me for all this work, to my mentors and colleagues, including a lot of them who are in this room, and then to the SCORE Fellowship and Accords for the excellent training and support I've gotten over the last 2 years. And this is my family. I've had twins during this time too. They're now 18 months old, but at the very beginning of SCORE, was out for a couple of months with these 2 nuggets. So thanks, everyone.
How about now? Perfect. So Dr. Amy Hipschman here in the room. I'll be facilitating the Q&A. We want to advance the slide also so that you can, I don't want to take away these beautiful pictures, but we do want you to see more about our fellowship opportunities while we're doing this Q&A. Yes. So excellent talks, both of you. I'll be happy for people in the room to raise your hand if you have a question and we can reflect it back. Do you want to take a microphone around? There is already one question in the chat as well from the Zoom, which is from Lisa Litterer saying, thanks for sharing this inspiring work. How do you see implementation science research as differing from health services research, if at all? And I was going to pose that to Dr. Dunstan.
Happy to take a shot at answering that question. So from my perspective, health services research is the overall umbrella term that implementation science fits within. So there's a lot of overlap between what happens in implementation science and health services research. But with implementation science, we're specifically interested in understanding how we get evidence-based innovations, so that be a program or a practice or a pill, directly into practice, and what the best process of getting that integrated into practice is and sustaining that over the long term. Where health services research takes a little bit more broad approach. So in my work specifically, I'm interested in getting the CARES innovation integrated into practice, but then like improving health or cancer survivorship care overall would be a more like health services research question, if you will. So I think with a lot of the work we do, we can kind of hit both sides of the same coin.
Well said, Dr. Dunstan. Anyone else in the room before I take the purview of the moderator? I'm looking around for hands up. I'll start while people are thinking. You know, they're digesting their food and their thoughts to bring questions to you all. So I'll start, Dr. Abbott. I was really intrigued in the pieces of what matters the most to families, and as you were talking about that piece of the work, and then also validating the questions. I imagine there might be many different, survey items, and that it has to be a forced choice of sort of where do you start? Could you speak a little bit to how you see that evolving in the process and where it is now?
Yeah, thank you so much. Yeah, it's been honestly like so interesting and rewarding getting to interview caregivers about the measure and figuring out kind of what is the most important and what is the priority, and kind of even getting into some implementation science questions of like, is this too many items? Like, would you fill out all these items? Caregivers in particular are just so motivated that they often don't care how long the survey is, but they really want it to be comprehensive. So they want it to feel like it would fully capture their child. And so it has, I'm not to the point yet where I've had to kind of start pruning or eliminating items. I'm more to the point of, I want to make sure it's comprehensive and that we've included everything we need to include before we think about cutting. And so have really been at the point of exploring, like, do you really feel like everything that you want to say about your child is in the survey? And that's led to the addition of some really cool items.
Wonderful. Thanks so much. And just in that vein, Dr. Dunstan, I'm just riffing off of this to think, what kind of outcomes have you heard in the interviews you've been doing so far with patients and clinicians and cares directors? Are there any things that have been bubbling up that are interesting to you to measure?
We didn't look specifically at outcomes to measure, but one thing that patients and cares directors felt very strongly about is the inclusion and consideration of psychosocial factors in this process. A lot of them really highlighted that the exercise was great and improving their physical function was great, but the biggest benefit from them was having that connection with other cancer survivors, having the benefits of interacting with a trainer on a weekly basis and someone who really understood what they were going through. And so we added a specific call out and consideration for referring just for psychosocial benefits, not just exercise alone. So I think that's one thing that is really important to patients.
Love that. Dr. Lum.
It's so nice to hear this work. Thank you both for great overviews of how you're combining methods with then also the specific content question that you have. So I wanted to ask sort of a different question as you think about the fellowships that you've been part of and think about transitioning to your next steps. Like, you've both been really successful at primary project, working on grant submissions, also thinking about publication, presumably. So, like, what will you look for in your next step to keep your momentum up? And second thing that you could reflect on is, like, have there been one or two primary things within the fellowship that have been really helpful tools for the balancing you've done?
Yeah, I think it's a great question because we're kind of both getting to the end of these fellowships, and it's the question's always, well, how are we going to keep this work going? I am lucky to have some foundation grants supporting this work. And so Ashley and I are going to continue our rounds of iterative interviews and refining the measure. And I do think by this summer, we'll be to a point of kind of publishing some of those initial findings. And so I think that to the first question of how you're going to keep your momentum, it's always just like, well, what's the next step? What's the next step? So finishing this round, developing this manuscript, submitting that grant. I mean, that's academic medicine, right? It's just always keeping kind of your next step on the horizon. And then two, in terms of like the most helpful things from the fellowship, I really think the different cores at Accords, having access to those resources. I had no idea how to rapid matrix analyze before this. That's the same method that we're using. I'd never really done qualitative research before. So having access to Ashley, Brooke, and the qualitative workshop and all of the resources that Accords affords has been just really instrumental in me developing this work. And then secondly, just getting to meet all together and do lectures, do work in progress sessions, learn from my peers has been the other really kind of influential aspect of the fellowship.
I agree with everything you just said. So I just want to echo your comments, but also like highlighting that I am considering where this work might lead me. So I am currently on the process of finding where my next step might be, whether that be here or at a different institution. And I think the opportunities I've had in the fellowship to present this work. I was just in Philadelphia last week presenting at the Cancer Consortium on Implementation Science. I presented what you saw today in 10 minutes. We really squeezed it down. But having the opportunity to network and present those things and, the opportunity to engage with not only qualitative support, but also quantitative support. I proposed, some mixed methods in my K99. And I think a lot of times you have to choose when you don't have a lot of funding, which portion you want support on. So having consults in both areas was really useful. I also think from a PhD perspective, being in a primary care research fellowship and then, being around so many clinicians, I'm often the only PhD in the room during mini courses. And I have learned so much from my clinician colleagues. And I think I also bring something to the table for them to learn. And so to see and learn how to collaborate with clinician scientists has been so valuable because I think a lot of people don't really get the opportunity to do that until later in their career. And I think a lot of times, in a more colloquial environment as peers, they can be like, hey, that didn't make sense. Like, I don't know what you're talking about. And I too can ask them questions. So it helps you learn like where you need to explain and, translate for your peers to make sure that collaboration is as efficient as possible.
Excellent responses, highlighting the value of accords clearly as part of these fellowships, and just showing you what's on the screen as well. Scores deadline is, as you can see, March 15th, so still can get those applications in, anyone who's considering applying for that. We do also have our applications open for the Accords Primary Care Research Fellowship due in May. You can reach out to me. Jacinda Nicholas was here, and you can reach out to her, or anyone in Accords can help you find us.
I had one more with
Please.
the last few minutes we had here. So you started mentioning a little bit about collaborations and teams. And so wanted to hear a little bit more about this work is all about multidisciplinary collaborations and what you've learned about those and how to do those well. Because it is a science in its own sense and how to figure out how to collaborate well. So I'd love to hear a little bit about that.
I can take this one first. I think writing a career development word is a great training exercise in team science and understanding how, like, what expertise you need and then how that expertise will be perceived by reviewers and other scientists. So I think having that experience of, okay, I need, an implementation scientist on my team. I need a primary care physician on my team. I need someone who is well-versed in oncology and geriatric oncology specifically. And so I think that helps you think through and have support to think through team science. But I also think our WIPs are designed really nicely to help us think about team science. We present in WIP, but we have people who are not always in our fields, and to understand like all the different perspectives that people bring and the unique feedback they give that advances the work in different ways. It's made me think about what I bring to WIP more critically, because I think some things you really need that content expertise on. And then other times it's really helpful to have someone who doesn't know your field give you feedback. So I think it's helped me see the value that everyone can bring in team science, not just the people like in my specific field.
Yeah, I completely agree with all those things. And a lot of the focus is on writing a career development award and how you get the different people you need on your team. And, that involves collaboration and conversations and really kind of working together and networking. And I feel like through our mini courses, like there's so many lectures about how do you go to a conference well? How do you network with people well? How do you ask people to be on your K? Like, how do you develop a mentorship team? A lot of things that seem like soft science, but are very needed to be successful in this space, and things that I didn't know how to do. I'll also say that getting involved in this work and, getting to the place I am in my career through SCORE has let me network with people across the country doing this work. It's just kind of a unique space and doing outcome measures work and having experience doing mixed methods that a lot of people aren't afforded that opportunity. And it's let me kind of be part of multi-site projects and be part of larger teams than I ever thought possible. So that's been very cool.
Well, I want to thank all three of you, Megan and Emily, for sharing your work, and Amy for helping us have a really productive conversation about this. If anyone online or in the room is looking for fellowship opportunities, I'll just point them out again. We have two really amazing programs. And as Amy said, the SCORE applications are due next week. And our primary care research fellowship applications are open and rolling. And then lastly, just that last plug for your evaluation. We love to hear from you all about your experiences that are highlights. Thank you all so much. Have a wonderful afternoon.